fourth patient in series. I am presenting the one 5-year-old male presented with chief complaint of bleeding per rectum after defecation since 2 years on and off. And according to the patient mother, child was well 2 years back. Then he passes the fresh blood after every defecation. Stool was not hard. There is no history of any constipation. Child passes stool 2 to 3 times in a day. Passage of the blood was regular and not associated with any type of the pain. Uh, Otherwise, patient was active, playful, and growing well. Currently, patient symptoms were worsened, and he came to KGMU for the treatment. History of present illness: there is no history of diarrhea, any food allergy. There is no alteration of stool color, no weight loss, fever, hematemesis, or abnormal pigmentation over skin and mucosal membrane. There is a patient is a second child of non-consecutive parents. There is no such complaint in family. On general examination, patient is well conscious oriented. Pulse rate was 92 beats per minute. Blood pressure was within normal limit. There is a pallor present, cyanosis, jaundice, and edema absent at the time of examination. Per rectal examination, multiple pedunculated polyp felt on the distal rectal examination. In view of above finding, we plan for colonoscopy and biopsy. This is a picture of colonoscopy. Multiple pedunculated polyps are seen in colon, and the biopsy suggestive of juvenile polyp with no sign of any atypia or malignancy. This is the multiple polyps seen in the colon. In the view of histopathology report, we want to rule out any other polyp in upper bowel. So we go for the upper GI endoscopy. Upper GI endoscopy is within normal limit. This is the report of upper GI endoscopy, normal up to D2. And initially, patient was managed conservatively with iron and B complex with stool softener, but symptoms were worsened and patient need repeated blood transfusion. So we planned for the total colectomy with ileal J pouch, with ileal anastomosis, with ileostomy cover. And we start the laparotomy and mobilization of colon was performed. This is a mobilized colon. And from this is the dentate line. We cut here and some mucosal tunnel was created. This is upper segment. This is a lower bowel. And after removing all the colon, we created the J pouch, 10 centimeter each limb was created. And with the use of linear stapler, we created the J pouch. This is the gross specimen we resected from the IC junction up to the rectum. And after cutting, there is a multiple polyp present up to the this specimen polyp present up to the transverse colon, but we cut here. Post-operatively, patient is doing well, accepting orally, ileostomy functional, and patient was this is a photograph of the patient post-op day 6 when we planned for the discharge. And thank you. Little bit discussion. This is a polyposis coli for the multiple, condition for the multiple polyp in the large intestine and used synonymally with familial polyposis. This is the autosomal dominant with incomplete penetrance. Individuals with JPS are increased risk of malignancy of colorectal and gastric cancer.
1 minute left.
Okay, sir. JPS is due to the germline mutation of SMAD4 or the bone morphogenic BMPR1 gene, and the clinical manifestation: juvenile polyposis in adult. Most probably they are symptomatic by age of 20 years. Overall, 90% of the patient present with bleeding and anemia due to the gastrointestinal polyp. Rectal bleeding is the most common presentation. Other presentation are abdominal pain due to the intussusception, or diarrhea due to the protein leaching enteropathy, rectal polyp. Sometimes they present with the epistaxis and other cardiac involvement due to the other extraintestinal involvement, hemorrhagic telangiectasia, hereditary, and they are increased risk of gastrointestinal cancer. There is a 17 to 25, 22% by age of 35% and 68% by age of 60 years. They are prone for the malignancy. That's why we need resection of these polyp to reduce the malignancy, and resection of colon or diagnosis when we suspect, when there is a more than 5 juvenile polyp in the gastrointestinal tract or multiple polyp, or patient with a family history with any number of polyp, we suspect the JPS. Differential diagnosis में Peutz-Jeghers and nevoid basal cell carcinoma syndrome and hematoma tumor syndrome. Screening we done, and what are our approach in KGMU for patient with a JPS? We cardiovascular examination with complete blood picture and iron deficiency anemia. We go for colonoscopy, esophagogastroduodenoscopy, and repeated annually if polyp are demonstrated, and additional evaluation of bowel pattern. Thank you.
Thank you, Dr. Rai.